Hey Doc, it's Nick. Thank you for submitting this case. This is one of those cases that looks somewhat, I would say, easy on the surface, but might have some deeper considerations that you may not find out until you've gotten through the case, or 50 to 75% through the case. But let's go ahead and take a deep dive into this and try to create what I would say is a predictable case, even though it looks easy. Let's start with freezing the molars. This is something you started doing more of. I think you and I did a case together where I had programmed freezing or making the teeth unmovable. You can make it movable, unmovable. That case really called for it. I'm not sure this case does. With that said, I feel like this is a technique that might be beneficial. And the theory is that if we have good interdigitation of the most posterior teeth, we're happy with this relationship, we're happy with the vertical dimension, we're happy with the posterior overjet, then maybe we just keep them in place, because I forget which Newton's law it is, but for every action is an equal and opposite reaction. It's pretty hard to move a tooth that doesn't have a brace behind it. It's almost like a cantilever situation. So if we just say we're not going to move this and we use this as our brace, it just makes the movement of the anterior teeth more predictable. And I think that's why you probably did that here. But I just want to say this is not something that I routinely have seen in my training. It is something I started doing, but I always want to be transparent when I do something that is Nick's hunch versus something that's been scientifically validated. This is definitely not one of those things. With that said, a lot of what we do with Invisalign hasn't been scientifically validated because it's such a new frontier for us. So I would leave those there like that, but I wouldn't always freeze them just because. There should be good reason to do it. Secondly, always starting with diagnosis, we have class 2 end-on molars, class 2 end-on canines on the right side, and then class 1 relationship on the left side. I'm sorry, that was the original, but I think you get the point. Yeah, so one side is class 2, the other side's class 1. I don't know why I got in the habit, but whenever I see that discrepancy, I always come and I look at the midlines. If I have a differential between the right side and the left side with my sagittal dental relationship, I'll say, all right, the midline should be off then. And then I say, is the midline off in the direction that I think it should be? And I do this exercise because it sometimes reveals other things that I didn't see. So if you look at this midline, you have to ask the question, are we off to the correct side? And the answer is yes. But as we go ahead and I'm probably putting the cart in front of the horse, I'm trying to stay in the diagnostic realm. But let me just jump forward to treatment. If we're going to fix this midline, we should always ask the question, how are we going to try to align this? Are we going to move the upper, the lower, or both? And the answer is always, it depends on where the upper is in relation to the face. So we should have photos, and I'm not going to bring the patient's photos up just for HIPAA reasons, but the upper midline is correct in the patient's face. Therefore, we're going to try to get the lower to match the upper midline. Very important thing to always ask, and this comes out of the world of Frank Spear's facially generated treatment planning. We're just using that concept in the world of orthodontics, where we ask, where should the midline go? Well, the answer is in the face, not the teeth. So again, this is the proper midline. If we're going to try to fix this, then we're going to want to fix the lowers. And it just happens to be that the lowers have, I believe, some crowding. Yeah, so that's a pretty easy midline to create, coincident with the upper based on how it's crowded. With all of that said, coincident midlines has been studied. Frank Spear talks about this all the time. The Vince Kokich study from the 90s, where they polled a bunch of orthodontists, general dentists, and lay people, and what they found is 10,000 foot view. coincident midlines is just not important. What's important is the angle, whether there's a cant to the midlines. But if they're vertically upright, they can be off by 4 millimeters before a well-trained eye would notice. But even at that point, beauty is not degraded as a result of it. So that's the takeaway. Actually fixing midlines much of the time, when I say fixing, getting them coincident, is actually rather difficult because there's often a skeletal aberration or asymmetry, a joint asymmetry, something that happened during craniofacial development that threw everything off. Not to mention it's hard to move teeth perfectly axial in a direction towards the midline without braces. So moral of the story, coincident midlines is not something we should make as a routine goal unless absolutely necessary or absolutely necessitated by the patient. In this case here, I think you're going to get there pretty easily, so you might as well go for it. Just know you're probably not going to get it there based on the next thing. So diagnosis number 3 would be the position of the central incisors. So this is the beginning, is rather incisal in relation to, let me just take a step back, only because I'm in the modified ClinCheck. See if I can go here. Be easier in this view. Yeah, okay. All right, so here's our pre-op. If we drew a line from the canine to the canine, not only do we see the canines are at different levels, but the centrals, the gingival zeniths don't match up to the gingival zeniths of the canines. They're actually below the laterals. We know, well, I say we know, we can see that happen because there's quite a bit of attrition from parafunction in this patient. We call this compensatory eruption due to attrition. Eruption compensatorily, in other words, the teeth have compensated in the direction of the attrition due to the wear. You can probably see the same thing on the lower. Yep. And the reason for this is teeth will continue to erupt until they meet an opposing force. Very seldom will we see an anterior open bite with patients who wear. So we see wear patients, we often see them coupling. Coupling meaning interdigitation of the upper and lower teeth. So diagnosis, compensatory eruption. The reason why this is important, when you see this in patients, this degree of attrition, it's extremely common that these teeth are not going to move as readily as the person who doesn't suffer attrition. And the reason for that is the bone's more dense. So Wolff's law says the more bone is stressed, the more dense it gets, the stronger it gets. That applies here. And the reason that's important is movement of these teeth, especially the centrals, has to be considered a less predictable movement, including the lowers, these guys down here. Really canine to canine, upper and lower. So all the anterior teeth are not going to move to the degree that you want. And when that's the case, you have a couple options. Before I tell you the options, let me just say getting that in 19 trays won't happen. You'll probably get 25 to 40% of that. In other words, it's going to look much more like it started at the beginning. Intrusion is a difficult movement. Intrusion in a case like this is extremely difficult. So understanding the patient and knowing what their foundation is made of is an important part of this. So option 1 is you could further intrude the uppers and lowers until you get either a 0 millimeter overbite or a -1 millimeter overbite. And if we come back over here, I'll show you what that looks like. Something like that. I can assure you, you're not going to get anything remotely close to this. I might do a little bit in the canines. And what we're going to do is just monitor it as we move forward. All right. with the intrusive force, you want to make sure that you have really strong rectangular attachments posteriorly. So I'd put a 4mm rectangular attachment on the molars. If we're going to intrude here, we're going to have an extrusive force of the trays posteriorly. One could say that this is enough, but I would confidently say add a 4mm attachment on both of these and secure yourself from that opposite reaction due to the intrusive force anteriorly. So that would be option 1. Option 2 could be, you could kind of mix and match these. So coming back to the original ClinCheck, you could ask the technician to slow down the velocity of movement by 50%. So you would write that in the tech comments up here. So I think by default, Invisalign moves teeth 0.2 millimeters per tray. If you ask for 50% velocity, they'll do 0.1 millimeters of movement per tray. What that does, it's a smaller movement per tray, which in a case where the bone is really solid like this, might give us a better chance to have a predictable movement. You could also increase the number of days. The jury's still out on exactly what the recipe is for number of days for cases like this where the bone is dense. But if you want something predictable in a case like this, I would do velocity, 50% velocity, and 10 days of tray wear would probably give you a much more predictable result. I would then check the patient, ask them how they're feeling. If you're getting, at tray 10, 100% movement from what you expected, then maybe I'll start dialing back to 8 or 7 days. No matter what you do in a case like this, I would do 2 weeks of tray wear for the first 2 to 3 trays. And the rationale there, this is something I do based on zero science. I say zero science. There's a lot of scientific underpinning to this recommendation, but there is no study that's been done that confirms this is successful. The idea is you're much less likely to have activation of the osteoclast in the first couple weeks based on the fact that you haven't really induced inflammation yet. It takes quite a bit of force and time to activate those osteoclasts. So whenever I see solid bone like this, I'm always going to increase the number of tray days that the patient's going to wear for the first few trays. I do 2 weeks for 3 trays. That's just what I do. I can't say whether that's too much or too little or just right. But definitely a case like this, it's something I would employ. Lastly, if you're ever going to do something like Propel, which is the microosseous perforations, this is the kind of case to do it on. Done a couple cases just like this where we did veneers on front teeth and patient had 100% overbite. If you want, I can share with you that case. I employed pretty much everything I'm sharing with you here. 50% velocity, 10-day trays, but we also did Propel around all the teeth. And even with all of that, in a year's time, we got 100% to go to 30% overbite. So these cases are pretty tough. This is a snake in the grass kind of case. Lastly, well, not lastly, but additionally, why do we fix sagittal discrepancies? We fix sagittal discrepancies if and when we want to improve overjet. So this relationship of the teeth, although not ideal, is not something we necessarily need to fix. Hey, guys, I'm recording something. All right, so we're gonna call it quits on this. I think we covered a lot of ground. So I would set the case up where you create 0 millimeters overjet.
I got peanuts too. Me too.
Add the rectangular attachments.
I got plants.
Hey, can you be quiet for a second, guys?
I got plants.
Hey.
Why?
I'm recording something. And then increase the proclination of these teeth here. I would also do the lowers too. All right, we're going to call it quits on that right there. Let me know how your modification goes. But let me just say, sometimes the easy cases are the hard ones. Good luck.